Sir, the certificate states that 6 trees will be planted in your name in ecotourism site at Songo, Sikkim. Thank you. Thank you so much, sir. And I now request our convener and moderator, Honorary Brigadier Dr. Arvind Lal, to take over. Thank you.
Good morning, ladies and gentlemen. I welcome all of you to Day 2 of FICCI HEAL Annual Conference 2024 and to this session titled From Policy to Practice, Advancing Primary Healthcare in India. For the past few years, a session on primary health has become a regular feature of the HEAL Conference. This underscores the importance being according to primary health as the most important lever to transform healthcare in India, especially with the Ayushman Bharat and Wellness Centers, or HWCs, now known as Ayushman Arogya Mandirs. FICCI, in collaboration with NatHealth and OMAG, which stands for Organized Medicine Academic Guild, is spearheading a novel industry-wide primary health initiative for the first time in the history of healthcare in India. The project is called Project Smart HWCs and aims to showcase the partnerships between private healthcare and state governments to operate model HWCs at the grassroots level, which can quickly be replicated elsewhere in the state and across the country. Today in this session, we will delve on opportunities for translating primary healthcare policy into actionable outcomes and how the private sector can collaborate with the government in this important endeavor. I am privileged to have a truly distinguished panel representing a diverse spectrum of expertise in India's healthcare landscape. Our panelists bring a wealth of experience from public health administration, policy advisory, pioneering healthcare technology, and industry leadership. This unique composition allows us to explore primary healthcare advancements from multiple vantage points, that is policy development, state-level implementation, technological innovation, and public-private collaboration. Without further ado, let me introduce these esteemed panelists to you. I would first like to introduce Mr. Rajesh Bhushan sir, who was the Union Health Secretary from 2020 to 2023 during the world's most pressing healthcare crisis, the COVID pandemic, and we are privileged to have him on this panel as during his tenure, nearly 90,000 HWCs were operationalized and the country achieved the target of 1.5 lakh or 150,000 HWCs. We are fortunate that Mr. Bhushan is now advising the health industry on Project Smart HWCs to unlock the potential of the private sector in enhancing primary healthcare. Thank you, sir. I would next like to introduce Mr. Parthasarathy Sen Sharma, sir, the Principal Secretary Health and Family Welfare, Government of Uttar Pradesh. He has the reputation of being one of the most dynamic IAS officers in the country, who is spearheading the health agenda in India's highest populated state. He has been instrumental in bringing together the private health industry and the UP government to implement the FICCI NatHealth OMAG's project, Smart HWCs. Thank you, sir. We are also pleased to have Mr. Rajiv Kumar Sen, Senior Advisor, Niti Aayog, who is driving transformational initiatives and strategies to advance healthcare systems at a national level. Mr. Sen brings a unique perspective on primary health with his combined expertise in economics and health. Sir, we would also like to meet you after this conference is over to discuss other things which plague people in general sitting here, which is public health spending and reimbursement rates of ABPMJ. Next, I would like to welcome Dr. Geeta Manjunath, founder of Nirmay. She joins us with a pioneering perspective on the integration of cutting-edge technology in healthcare. Her innovative work in breast cancer screening has the potential to transform early detection of the #1 cancer in women in India. And last but not the least, we have the illustrious Mr. Siddhartha Bhattacharya, Secretary General Nat Health. Siddhartha has a deep passion and years of rich experience in primary healthcare, focused on PPPs, promoting innovations to improve health delivery models, healthcare financing, and promoting output-linked KPIs. We are excited to hear from each of these esteemed leaders as they share their insights on how we can collectively drive progress in primary healthcare across India. I would now like to set the context for this session before inviting the panelists to share their insights. Primary health is the fundamental pillar on which strong health systems are built. It not only plays a vital role in preventing diseases and early intervention, but effectively primary health also reduces the burden on secondary and tertiary care facilities, decreasing healthcare costs and enhancing patient outcomes. In other words, primary healthcare is the most important aspect of delivering universal healthcare to our population. With this as the backdrop, in the National Health Policy 2017, the government envisaged moving from selective primary healthcare to comprehensive primary healthcare via health and wellness centers, or HWCs, to expand the range of services at primary healthcare, including the non-communicable diseases, that is NCDs or lifestyle diseases, which are responsible for 2/3 deaths in the country, specialty services like eye, ENT, and mental health, services for elderly care and palliative care for chronic patients, and emergency care as a first port of call for healthcare. In 2018, under Ayushman Bharat, the government announced upgradation of 1.5 lakhs or 150,000 existing primary healthcare facilities into HWCs by 2022. During the announcement, the government also invited the private sector in the form of the CSR contribution, philanthropic foundations, NGOs, etc., to partner in successful running of these HWCs. Today, there are more than 1.7 lakh or 170,000 HWCs functional across the country. However, these HWCs often face constraints in infrastructure, funding, manpower, technological resources, and availability of drugs and diagnostics, which limit their ability to function effectively. Given the scale and diversity of healthcare needs across India, it is neither practical nor feasible for the government alone to address these challenges. By partnering with the private health sector, the government can leverage private expertise, innovation, and resources to address these gaps. The private sector can also help streamline services, introduce advanced early diagnostic solutions, and support workforce training. In 2022, FICCI's Swasth Bharat, that is Public Health Task Force, took the lead for the health industry to partner with state governments to work collaboratively in select HWCs to uplift them as smart HWCs. The idea was well received by the industry, and Nat Health and OMAG joined hands with FICCI in this first of its kind initiative, bringing together 300 plus members from the health sector. Groundwork for the project Smart HWCs was laid by our personal philanthropic initiative, that is Arvind Lal Vandana Lal Foundation, or ALVL Foundation, where we have been working with NHM Uttarakhand on the project since 2021. We started with 3 HWCs, and today we are partners in 70 plus HWCs in districts of Almora and Pauri Garhwal, which includes 25 HWCs in an aspirational block called Dugadda in Pauri Garhwal. In 2023, FICCI proposed to partner with Government of UP for Project Smart HWCs, and in January this year, an MOU was signed with NHM UP to partner with 30 HWCs in the Sarojini Nagar block of Lucknow. Is Dr. Arun Agarwal here? He's not here. Dr. Arun Agarwal did his internship 30 or 40 years ago in Sarojini Nagar block of Lucknow. While we have a long way to go before these HWCs can be truly termed as smart HWCs, we have witnessed significant early gains in the partnership. Some of the priority areas and the interventions in both Uttarakhand and UP include training and capacity building of the HWC staff, where we are involved in training of 500 plus primary health workers in Almora and Pauri, and 300 plus primary health workers in Sarojini Nagar, Lucknow. The focus is on supplemental or refresher trainings on clinical knowledge and practical aspects of successfully delivering care in these HWCs. These trainings especially emphasize on the expanded range of services and new components introduced in HWCs, such as telemedicine, phlebotomy services and point-of-care diagnostics, online drug indenting via e-Aushadhi or DVD-MS, which stands for Drugs and Vaccines Distribution Management System Portal, etc., etc. Then is community outreach to channelize more people to avail primary health services in these HWCs by creating awareness in the community about importance of primary health, enhanced scope of HWCs, and the new services added, which are about 200 community outreach activities in the form of health camps, screening camps, thematic awareness sessions are conducted in a year in Almora and Pauri, and 100 plus such activities have been carried out in the Sarojini Nagar block, and nearly 400 more are planned for the current financial year with the support of Dr. Lal Pathlab's CSR Foundation. Introduction of cost-effective innovations across various areas, for example, our work with Niramai for early detection of breast cancer in women, where more than 1,000 women have been screened in Almora over 3 months, and nearly 200 women were screened in Lucknow last month as part of the Breast Cancer Awareness Month campaign. Dr. Geeta Manjunath will share with you more details of the innovative technology used and its scalability. I must put on record that screening women for both breast and cervical cancer has been a challenge due to the inherent cultural hesitancy in rural women. But I am happy to share with you that all under the FICCI, Nat Health, and OMAG project, Smart HWCs in UP, we are launching screening of 5,000 women for breast and oral cancer and 5,000 men for oral cancer using innovative tech-enabled screening solutions in December with the support of Fortis Healthcare's CSR. I would like you to put your hands together to thank Fortis for this initiative. Another example is the introduction of ECHO training program for capacity building of more than 160 community health officers or CHOs in Almora. Based on the success and scalability of the program, Government of Uttarakhand has now scaled up the program for all CHOs, that is more than 2,000 CHOs of the entire state. Next is the hub and spoke model of essential diagnostics, where block level hub lab is established to perform 45 to 50 tests on site, and all other HWCs within the block are connected as spokes, where patients can get their samples collected. Our field executive, who's in layman terms known as a delivery or a pickup person, transport the samples from spoke HWCs to the hub lab, and after testing at the hub lab, reports are sent back to the spokes electronically. The entire operations are digitized with the help of a lab information management system, or LIMS. In Almora, more than 70,000 tests have been done in 2 hub labs operationalized in mid to late 21. This marks an increase of 144% in utilization of the hub labs. And in Lucknow, a hub lab has been established in CHC Sarojini Nagar, operationalized in August this year. The spokes are being connected starting next week on 11th November, but you will be happy to note that operationalization of the hub lab alone has led to an increase to the tune of 300% in number of tests carried out and 220% in numbers of patients served. There are several other interventions underway in both the states, about which you can read in the discussion paper on HWC, which was released yesterday. We are confident with the dynamic policy makers like Mr. Bhushan, Mr. Sen Sharma, Mr. Rajiv Sen, along with the industry partners like Fortis Healthcare, Dr. Lal Path Labs, Merengo Asia, Ujala Cygnus, Roche, Niramai, Astron Healthcare Consultants, ALVL Foundation, DigiSwasth Foundation, and many more, we will be able to showcase accessible, high quality and sustainable smart HWCs and create a replicable model for HWCs across India. With this, let us dive into the session, and I would first like to request Mr. Rajesh Bhushan to give his comments.
Very good morning to all of you. Dr. Lal. We also have sitting along with him Parthasarthi Sen Sharma, Rajiv, Siddharth, and Geeta ji. Ladies and gentlemen, let me quickly start from the evolution of the primary healthcare, particularly structured interventions of the union government or the federal government or government of India, and the role that the states played, and then come down to what are the challenges that we face. Probably our other colleagues on the dais would also be touching on some of these points. So it was in 2005 that Government of India for the first time launched a very structured intervention which was centrally sponsored, and it was called National Rural Health Mission. What was National Rural Health Mission? It said that health facilities should be made accessible, they should be made affordable, and they should be quality health care, which means that there should be minimum standards of what kind of health services should be provided, and then all the health facilities at that point in time, they were known as health sub-centers, primary health centers, community health centers, subdivisional hospitals, and district hospitals. This was the hierarchy till the district level in 2005. So the government said that everyone should have a health facility at a walking distance. That is what accessibility means, or maybe doorstep. Government also said it should be affordable, it should be free, the drugs should be free, the diagnostics should be free, the referral should be free, so on and so forth. Government also said that whatever health care we provide through the government setup should be quality health care. So this was the aim. Then in 2013, government said that this commitment should not only be for the rural areas. What about our urban centers which are emerging? What about these semi-urban or peri-urban areas? We need to have the same structure there. So from 2005 to 2013, based on the learnings, the union government said we will now convert this program from National Rural Health Mission to National Health Mission, which means that for us, urban areas and rural areas are almost the same, although the challenges may be different, but we would have a structured intervention across the country in all these areas. So this program, which began in 2005 roughly with 3,000 crore annual allocation Indian national rupees, today is a program which has an allocation of 33,000 crores in terms of Indian national rupees. This is equivalent to budget of multiple union ministries taken together. Although the union health budget is 90,000 crores, within which 33,000 crores is a huge or a significant amount. Then, as Dr. Lal said, in 2017, so we have talked of 2005, 2013, and now in 2017, government came up with a new policy called the National Health Policy. And one of my very close friends at that point in time was the Union Health Secretary, Mr. C.K. Mishra, and that policy saw a paradigm shift. In what terms? It said that health is not what happens in healthcare facilities. Health is not what happens in hospitals. Health is not treatment alone. Health is preventive health and health is promotive health. Right eating is health. Right amount of physical activity is health. How to ensure that I am free from disease is health. Population level screening, Geeta ji, is health. I may be perfectly fine, but I need to be screened for hypertension. I need to be screened for common cancers, breast cancer being one, oral cancer being another, cancer of cervix being the third. So, all this, the paradigm shift was in terms of focus shifting from treatment to preventive, promotive, and curative health. So, this is what happened in 2017. It also said, which brings me to the focus of this discussion today, that whatever money Government of India spends and state government spend, we have Partha from Uttar Pradesh, 2/3 of that amount should be spent on primary health. So this was a national commitment. 2/3 of whatever we spend must be spent on primary health. Then in 2018, as part of this paradigm shift, came the concept of Ayushman Bharat, which had 4 sub-programs: Ayushman Bharat Health and Wellness Centers, which are today known as Ayushman Arogya Mandirs. So these are the first port of call. If I am a local villager, say in Sarojini Nagar block, or in Almora, or in Dugadda, as Dr. Lal said, where would I go first? If I have a problem regarding my health, I would go to this health and wellness center. So 1,70,000 odd, is that the number, Rajiv, today? Okay, so 1,174,000 such health and wellness centers have been operationalized across the country, of which 90,000 was done during my tenure when I was there in the health ministry. So what do? They again focus on prevention, promotion, and screening of health, also on palliative care. There is another part of this Ayushman Bharat, which is Pradhan Mantri Ayushman Bharat Health Infrastructure Mission. This was a direct fallout of the COVID management. The government of the day, both in the center, that is New Delhi, and in the states, realized that if I have to get tested for COVID, molecular diagnostics, why should I be asked to travel to a clinic which is, 10 kilometers or 20 kilometers away? Why can't I have a block level diagnostic lab? So this part of Ayushman Bharat, which is popularly called PM Abhim, said that every block of India would have a diagnostic lab, and there substantial progress has now been made, and that is where ALVL Foundation is also playing a very important role. So that's only one component of what is being done. So what happened as a result of this paradigm shift? As a result of this paradigm shift, what also happened was that our primary health or health and wellness centers, rather than only providing reproductive child health services, that is looking after pregnant mothers, lactating mothers, newborn babies, slightly grown up adolescents, and looking at communicable diseases, TB, malaria, so on and so forth, they also started looking at NCDs, non-communicable diseases, or what we popularly call the lifestyle diseases. Because lifestyles have changed, both in rural areas as well as in urban areas. So therefore, you have almost equal incidence of cancers and hypertension and diabetes in rural areas as you have in urban areas. So that older notion कि ये सारी बीमारियां खाली शहरों में होती हैं has now been junked. So this movement happened. So there are 12 packages of services that are supposed to be provided free of cost at these health and wellness centers, 1,70,000 odd across the country. And there is this army of grassroots workers called accredited social health activists, or popularly called ASHAs. ASHAs may not necessarily be educated. Some of them are illiterate, but they are intelligent people. They've been trained. Some of them are standard 5th pass or 6th pass or 10th pass. and they are responsible for 250 families in their village. So they have the entire details of these families with them. Why? Because all health interventions have to be implemented through ASHAs or have to be mentored through this network. Today we have more than 10,70,000 ASHAs across the country. So what is happening as a result of all these changes? In brief, what is happening is that for the first time we have household wise line listing of people. And when we have household wise line listing of people, we also know which are the countries, which are the households which are facing hypertension, diabetes, cancer, any other disease. This was not the case before 2017. This is a huge change, and this is a significant amount of data. Most of it is already digitized. What needs to be done is data analytics and data mining, keeping the concerns of privacy and data security in mind. So this is what major challenge we would face going ahead. Another challenge is, once you have a line listing of households, you should be in a position to do early surveillance and early warning. Suppose there's an outbreak of a disease in, say, a village in Kerala, Nipah virus. Let's take a real life example. Why is it that in real time the state headquarters and the union headquarters, that is Nirman Bhavan Health Ministry, do not get this information when you have line listing of all households? So there is some crucial piece missing. So that is the challenge going ahead. Similarly, basic management of diseases at the primary health level. If I am suffering from malaria or dengue or chikungunya, and I go to my primary health center, where I would encounter not a doctor but a community health officer, CHO. She's a BSc nurse who's as good, educated, trained. Why is it that my basic management is not happening there? Is it because of lack of training? If yes, then can that training be done in conjunction with private partners? The answer is again yes. Can it be done on scale? The answer is again yes. Why is it not happening? That is something that we need to deliberate. Then, apart from basic management, the primary health facilities, which is these Ayushman Arogya Mandirs, can also do counseling. They must do referral and act as gatekeepers. Even if you are suffering from common cold, you should not all be going to district hospital. Or in Delhi, not everyone should be, queuing up in AIIMS, New Delhi. Why should you go there? That is because no one is doing the gatekeeping at the referral stage. So can this gatekeeping be done again, taking help of the private sector? Yes. Can such models be evolved? Yes. Have they been evolved? Yes. Have they been implemented on a scale? No. Because in a country of 140 crore people, you cannot depend on pilots. You cannot for long remain confined to Sarojini Nagar. You have to go out, you have to do things on scale. Otherwise, they won't register. Similarly, once you have done gatekeeping and referred people who need referral to medical college hospital or district hospital or to AIIMS, now we have 21 AIIMS across the country, someone needs to see whether treatment adherence is being done. You have sent me, you have done my breast cancer screening, you have sent me to AIIMS, they have prescribed a drug regimen. Now, whether I am sticking to it or not, who looks after that? Someone must. Otherwise, all this investment in terms of time and money goes waste. So, treatment adherence again needs to be monitored. Similarly, follow-up and care needs to be monitored. Now, there are certain things where ideally the private promoters or private sector should not be going. For example, creation of physical infrastructure at primary health care level. that is something where the union government as well as the state government is flush with money. So additional rooms in PHCs, water connection, electricity connection, drainage, solid waste management, all these things, please leave it to the states as well as to the union government to do. However, training, use of technology, use of machine learning and artificial intelligence, community engagement, these are areas where a thriving partnership between private sector and the union government becomes important. I would rest my case here, and I once again thank you for having given me this opportunity of addressing you, and I hope that we'll keep on interacting on this subject, which is of utmost importance to our country. Thank you.
Thank you, Mr. Bhushan, sir. Now I'd like to invite Mr. Parthasarathi Sen Sharma to share his thoughts. So you can, from here, there, wherever you want.
A very good morning, dignitaries on the dais. Thank you for inviting me. Thank you for giving me an opportunity to present the viewpoint of a state government. First of all, I would like to thank Dr. Rajesh Bhushan sir, because he said everything that I wanted to say. So it's very difficult for me to now say anything. However, let me give you some perspective on the state thing, especially from the state of Uttar Pradesh. Let me start with certain figures. Uttar Pradesh right now has operationalized almost more than 21,000 Ayushman Arogya Mandir, which is what we are talking about, the primary healthcare center. And as Mr. Rajesh Bhushan pointed out, the Ayushman Arogya Mandir is the main change which has happened in the last 3-4 years in terms of primary healthcare in the public sector. Out of this more than 21,000 Ayushman Arogya Mandir, they are not all same. Around 17,000 odd are the Ayushman Arogya Mandir, which are the rural Ayushman Arogya Mandir, which is what the sub-centers were converted into. So what exactly is that they? Previously, there used to be one ANM in these sub-center who used to basically look after RCH activities and vaccination activities. And she used to move from village to village also. So there was no surety that the ANM would be there. Now the change has that apart from the ANM, now there is a BSc nursing graduate called a community health officer stationed there, who is supposed to be doing OPD every day. The second point is that there is an essential drug list now prescribed. So these drugs should be available there. There are certain 14 diagnostics that should be available there. The teleconsultation facilities should be available there. So this is how this rural Ayushman Arogya Mandir is different from the old sub-center. But the other Ayushman Arogya Mandirs, the PHCs, the Ayushman Arogya Mandir of the urban areas, they are a bit different because they have an MBBS doctor. So there are two classes of Ayushman Arogya Mandir in one way that we are saying, but actually when we usually say Ayushman Arogya Mandir, we are talking about this rural sub-center based Ayushman Arogya Mandir. In terms of scale, as I pointed out, we have around more than 21,000 Ayushman Arogya Mandir, of which 17,000 odd are this sub-center thing. Right now, as I speak, our advertisement is out for the recruitment of 7,400 CHOs more. So we will be operationalizing that many more Ayushman Arogya Mandir in the months to come. The essential qualification being BSc nursing. On an average, so of these 17,000 I'm talking about, on an average, 20 OPDs happen every day. On an average, around 4 to 5 diagnostics happens every day out of these 14 diagnostic packages. On an average, 3 to 4 teleconsultations happen every day, on an average. The average sometimes, hide many things, but on an average, what we are talking about. So on an average, in UP every day, around 75,000 to 80,000 teleconsultations would be happening with this Ayushman Arogya Mandir as a spoke and the hub in CHCs or in the district hospital or in the medical college. This is the scale that we are talking about. We have something called DVDMS, as Dr. Arvind Lal pointed out. So this is a drug and vaccine management system. This is an online system. So we can actually see which CHO has indented when and which CHO has not indented for the last 6 months. which is a clear proof that the OPD is probably not functioning. From this online system, we can see which Ayushman Arogya Mandir's teleconsultation is not happening. There must be some problem there. So apart from the services, this online systems helps us to monitor. We have a few online systems which help us to monitor these. The first is what is called the attendance management system. This is the CHOs in our state. It is not universal. All the Ayushman Arogya Mandirs are geotagged. So the CHOs, when they go with their smartphones, and they all have a smartphone, they are supposed to give their attendance in this geotagged area, and we can find out which of the CHOs were present when. And around 85% of the CHOs are on any particular day giving attendance on the AMS. That is the first thing. If the CHO is not there, if the ANM is not there, then nothing else would happen. Second is this DVDMS, so we can find out which CHOs are indenting medicine. Third is the teleconsultation. We exactly know which. The quality can be a bit unreliable, because when we expand too fast and we expand and keep monitoring the numbers, sometimes that is a liability. But we are aware of that, and that will be the next step. So this is the present scenario in terms of what we are trying to do. But apart from that, we have an ASHA, as pointed out, which are around 1,70,000 in Uttar Pradesh. These ASHAs are intrinsically linked to the Ayushman Arogya Mandir. Again, not in every state. Our state, every ASHA has a smartphone and every CHO has a device. The population has been enumerated and 100% digitized in terms of around what in a system called eKavach. Nothing is 100%. When I say 100%, it's always 90%. So this population is enumerated, and we, on that enumerated population, we add on modules of RCH, we add on modules of NCD, so we know exactly which line listing, digitized line listing population has been done, CPAC form has been filled, whose NCD screening has taken place, or who has been given vaccination and who has not been given vaccination. So that is what we are talking about. Now, the second part is where we go from now, here. What is our challenges? Our challenges, as rightly pointed out, is first is the capacity building. The CHOs are, after all, a BSc nursing graduate with different kinds of nursing colleges in this country. When we expand these packages, we are expecting a lot many things from the CHO and the ANMs. So the capacity building and continuous capacity building is one area in which we have to work. And here, digital technologies can play a very, very significant part. I think we are still underestimating the potential of digital technologies for training. When my mixie gets bonkers in my home, I go to YouTube. I don't go for any training session. So I think we are not using the digital technology for training to the extent that we can. We have in our state, again, a YouTube channel for training of doctors only. It is called Shukravar Ki Sham Doctors Ke Naam. Every Friday, a new training module is uploaded, and thousands of doctors all over the state view that regularly. So I think we should be using this platforms for continuous training of the CHOs. The second challenge is community mobilization. The community's faith in these systems, especially in urban areas, this is a problem. Because even if you have an MBBS doctor, you have a Ayushman Arogya Mandir functioning, they still like to go to the district hospital or the civil hospital or whatever is the big hospital. Because so the capacity utilization, the utilization of this Ayushman Arogya Mandir and connect with the community is a challenge. The third challenge is how to use the tele-technologies effectively, not only teleconsultation but other tele-technologies. In tele-diagnostics, for example, this is a challenge, and I think these three challenges are things which we have to work. Fourth challenge is the urban area. Our entire model is actually a rural area which has been transposed onto an urban area. Urban dynamics works in a very different fashion. There, the ASHAs do not have that kind of linkage with the families. The Ayushman Arogya Mandir do not have that intrinsic linkage with the village as it happens in rural areas. We are still grappling with the right model for urban areas. Now, having said where we are and where we want to go, I want to now come to what I expect from the industry. Okay, after all, I have not traveled from Lucknow only to tell what I have to say. So the first is a reasonably uniform CSR spend. If you go into the CSR portal of Government of India, you will find that 5,400 crores is the annual CSR spend in Maharashtra and 1,100 crores is the annual CSR spend in Uttar Pradesh. The CSR spending should not be based only on convenience, that my business is in Bombay, so I will put it in Maharashtra. Your profit is not only coming from your product and your manufacturing, it is coming from a market. And Uttar Pradesh deserves far higher spend of CSR compared to other states. I think it is a point that should be kept in mind while the CSR foundations and the companies spend on the CSR. Second, I would like that, you had a session yesterday about regulations and ease of business. Now, this ease of business in health cannot be left completely to market forces because of the information asymmetry and also because of it is health. So if the industry wants an ease of business and less regulation, then the industry must come out with their own code of ethics and code of transparency and their own implementation system for this code of ethics so that we don't interfere in your work. I think it is time that the health part of FICCI or CII or other industry body, they or Nat Health come out with their own code of ethics and transparency so that we do not interfere. If you do not do that, the government will be interfering. Third is, and this is not only for health industry, the entire industry should also be cognizant of the environmental risks of your operations. The pollution, the negative externalities in economic sense. What is the industry doing about that? The people who are in the lead battery business, for example, or in the paint business, for example, chemical business, for example. Health is everybody's business. So I think it is a time for some self-regulation in that area also. Fourth is policy advocacy. And this is not only once in a year seminar, or it has to be continuous. What are you talking about when you're saying that we want a policy change? What exactly are you talking about? Which government order you want to be changed? Which law you want to be changed? Why? So that kind of work we expect. And next point is that innovative technologies. Many of the industry partners here have innovative technologies. When you try to sell an innovative technology to government, yours is the only product, for example. So there is something called a health technology assessment. Many people know that, many people still don't know that. If the government has to procure an innovative technology, I think you should go through the health technology assessment mode and get your product and your technology done, this health technology assessment done, because before that, without that, it will be very difficult for any government to procure that. In two areas, I think the industry is well poised to help us. One is the telediagnostics part. We are in UP anyway doing a lot of telediagnostics. All the CT scans are on PPP basis, or our X-rays are on CT scan basis. But there are other options available. This is, and to create a hub, we have the spokes, but our doctors in the hub are overloaded. So can we have an hub for teleconsultation and telediagnostics, which is industry supported? There is a business opportunity there, but there is also a CSR opportunity there. And lastly, as Mr. Rajesh Bhushan pointed out, the health promotion and prevention is still not up to the mark. We are still talking about treatment. I think health has been for too long left to doctors. So it is always about treatment. It is less about promotion and prevention. And that is where new technologies, digital technologies can be used for promoting healthy well-being and to promote healthy habits. I will rest my case. Thank you so much.
Can we have some slides of which Mr. Parthasarathi Sen Sharma has brought with him?
Not that one, the earlier one which I sent. This is basically the figures that I was talking about, the drugs, the diagnostics, the OPD, and AMS portal. So that I have covered. I just wanted to show you one map. If it is available, then it's fine. So how does this happen? This is how we monitor through the attendance management system. Exactly how many CHOs, how many have punched, in which districts, how many. So at the state level, I can monitor this on an average. This is daily. So this is 25th October, 84% of the CHOs had done the AMS punching, and it is district-wise, we can see the position. But at the district level, they can know exactly which Ayushman Arogya Mandir CHO punched and who didn't. This is how we monitor the teleconsultation on a daily basis. So this is the active CHOs on that particular day who were active on teleconsultation, which is the average teleconsultation. That day was 5.28 teleconsultations happened. How the districts are being monitored. So the orange ones are on the left side is the problematic area. Mirzapur, the CHOs were less active. But we also monitor the hubs, because if the medical officers are not active, then the spokes cannot do on their own. So this is how the hubs are being monitored. 42% of the MOs on that particular day were active on teleconsultation. And we have to understand that the MOs are anyway quite overloaded. So that is why the need for a separate hub. An average teleconsultation by an MO was 14.50 per day. We can see the inter-district variation, and this is done on a daily basis. So this is in numbers, the teleconsultation on that particular day, 5.28. If you see there's two columns. One is the teleconsultation and one is the teleconsultation through Apollo. So we have a teleconsultation partner also. So that is why I just wanted to show how it is being done daily on an operational basis. Thank you.
Thank you, sir. Thank you. So now I'd like to request Mr. Rajiv Kumar Sen to share his insights on primary healthcare. And as I mentioned earlier, he's from Niti Aayog.
So, very good morning to all of you, and my regards to the esteemed guests on the dais and to all the people here. Now, my job is even tougher now. So, I had Rajesh Bhushan sir, who gave the whole perspective in a very comprehensive manner, and Partho giving the perspective from the states. So, I'll not go into the details because you have heard. So, basically, there are three aspects when you look at it: accessibility, affordability, and the quality part. So this is the design of the scheme. And as has been explained, we have made progress. Obviously, in the access part, we have progressed the maximum. 1,74,000 AMs have been set up. The cost part, as you know, a large proportion of the OP comes from the medicines and diagnostics costs at the primary care level. That also, substantial progress has been made, but there's a lot of ground still to be covered. But I think the focus is on the quality. That's where we need to traverse the longest. And for quality, I think there are many aspects to it, some already touched. I would just like to mention a few. As Rajesh Bhushan sir had said, predictive, promotive, preventive. I think we also need to add predictive. Yesterday, there was a seminar in Niti Aayog where one of the esteemed members of ESC was making a presentation based on the household consumer survey that was recently published. And what was noticed is there is a huge change in food habits. Cereals have come down significantly, consumption of cereals. Consumption of items like pan, masala, tobacco has gone up. So I think, and this is where, to my mind, at the design level, private sector can play a very important role. Of course, the other roles are also there. To suggest and to come up with, early signs that these are the areas where we need to focus immediately. Of course, these all lead to NCDs. But then even within NCDs, I think there are some which needs more attention, the cancers, the more, the frequent ones, diabetes, then your hypertension. But even with this change in pattern of food habits, what could be the new diseases that needs to be focused? I think this is an area where private sector can play a very important role through AI, ML, and through other technologies. So that's one area where I feel it could be done. Secondly, of course, is the area of the diagnostics. As you know, there are many states where private sector through the hub and spoke model, as Parthaji has already mentioned, they are active. But again, scalability is an issue. You know, in a country of 140 crores, if we are doing something in one village or one taluka or one block, I mean, that's not the ideal way to scale up. I think these experiments should be done at a pilot, at least at a district level, and then the results could be brought in that can be scalable. So that is one aspect, and then there are many new things. There are also these hospitals which can be set up overnight, with basic facilities. So these are things which needs to be looked upon, and I think these are the state should be the main carriers for this, because if all these experiments can happen in states, and they should be more receptive to these ideas, and center can only facilitate. From the NITI side, we have always been suggesting that private sector involvement should be there. However, how it should be done is best left to the states. So that was my second point. Thirdly, urban centers, as Parthaji has again already mentioned, the model that we have today is very good for the rural. But in the urban centers, I think there are challenges. The model is not working as well as it is expected to be. So there we need to find variants, how we can make it more accessible, given the paucity of land, given the setup that we have, how things can be made better. AI and ML, of course, I need not emphasize, that is known, that these are the tools with which we can make up for the shortages. One, of course, is the human resource part. As you know, we don't have so many doctors that we need. We don't have medical staff. Partly that can be made up through technology, and I think that is something where, again, private sector can be the pioneer. They can teach us. I think in NITI there were many, we had cases where they said that they have set up this AI through which they can, based on the data that is already there with the arms, they can build a predictive model of what would be the, the diseases the serious diseases that could be coming up based on the data that they have. So these types of things adapted to the local conditions can be something which the private sector can definitely come up with. Other than that, of course, on the telemedicine, again, I think when we are looking at policies, we should look from the individual perspective. So today, telemedicine is catching on. That's true. It has grown many folds, but there are issues. A person to whom I talk today and discuss for my medical, help and support, the next time when I talk, it's a different person. So this, is something which we need to avoid, or we need to develop some mechanism through which there is a continual interaction between the same persons on both the sides. So even with the policies that we have, how we could dovetail them to enhance the impact and the efficiency is something which again needs to be looked into. So these are some of the broad ideas that I had. I think if there's anything else, I would be happy to answer during the question answer session. Thank you.
Thank you, sir. Next, I would like to invite Dr. Geeta Manjunath to share with us the innovative breast cancer screening technology developed by her company, Niramai.
Good afternoon, everyone. It's a pleasure and privilege to share the dais with really accomplished people on the stage and excellent people in the audience as well. So I present to you innovator, AI scientist, a technologist view of how we can impact primary healthcare in India and be the leader, maybe in the world, showing that how technology can really make a difference to move from a sick care industry to really healthcare and wellness oriented industry as well, even under the scale that is needed for a country like India at an affordable, accessible, and as was said, quality healthcare that's possible. So I'm founder CEO of Niramai. This is a startup based out of Bangalore, but we have people all over India now. Small startup, we are trying to do our best to build a new method of detecting breast cancer that can address this largest problem in women's health today. 684,000 women die every year because of this disease globally. which means 2,000 lives going every day unnecessarily, because breast cancer is completely curable. The only thing that we need to do is early detection, or if possible, earliest detection in stage 0, stage 1. And if you look at India, you're losing one lady every 6 minutes, and one person is getting detected with breast cancer every 3 minutes. Yes, we see close to 50% mortality rate for a disease which is completely curable. This has become my mission to stop deaths due to breast cancer in the last 7 years. I was comfortably in a corporate, heading AI research and so on, and then when I lost a couple of my close friends and family members to this, I said, we should attack this, and I'm so glad we're getting a lot of support from the ecosystem to do this. Let me share very briefly the story, and then put across to people here what are the things that we can do to really scale these kind of technologies. So what we present to you is a new method of detecting breast cancer, where we just measure the temperature variations on the chest using a thermal sensor. It's like one of those cameras placed in the center, much smaller, I would say, right? And we've all seen a thermal sensor during COVID. We were getting into a government building, it was checking temperature. Similar one, but a high-resolution thermal sensor. Measures temperature variations on the chest, which means for every person, we measure 4 lakh temperature points, very, very accurately, highly sensitive temperature points, which can measure differences of 0.02 degrees Celsius, right? You think about almost every tissue's temperature being measured. So we use a very high-resolution thermal sensor. And when you have so much of data, 4 lakh points every person, and showing it in color and so on and so forth, it's very difficult for bare eyes to detect whether there's an abnormality or not. And that's why we bring in machine learning and AI and deep learning, all the good stuff, to convert this 4 lakh temperature points to a cancer or breast health report. With this, we have proven, clinically proven, to detect cancer much before a hand can feel a lump. Hand can feel a lump at 2 centimeters or 2.5 centimeters, which is by DNM staging definition is stage 2, stage 3 or more. Till then, no one comes. Even our standard screening method today is clinical breast examination. Self-breast examination doesn't even work. So even ANMs are going and touching, figuring out if there is a lump. So even with our current infrastructure, we're only set to detect stage 2 or stage 3 above, which can have 50 to 70% survival rate. Depends on how early, even in stage 2, you have detected. It works for women of all age groups. Why is it important? Because some of the tests that we have today work only above 45 years. And we all know, many of us know, and it was referred to yesterday, that the demographic of cancer in women today in India, unfortunately, is different. The mean age for breast cancer in India is 10 years lower than the world average. Younger women are getting affected. So we need a test which can work for young women, older women. Young means like maybe about 25. I'm not talking about even younger. But yes, we have detected a 17-year-old with breast cancer with this device, by the way. No radiation, there's no side effects. Of course, it has to be affordable. And most importantly, portability. What you're seeing is actually a picture, and I'm going to show the device. Our friend Sanya is here with the device as well. So it's like really portable, like exactly this camera, put it in a backpack, go to the rural areas, and every house as was detected, and we can do it. And of course, we have done several pilots with ALVL team as well. And the best is the experience. No one sees or touches the person when the breast screening is happening. This is not promised by any test today, where we have a booth-like thing, like a changing room. The lady enters, no one is inside, closes the door. She sits in front of this device for about 5 minutes. We blow cool air to make sure that, that she's prepared, and then 2 minutes of imaging. That's it. She comes out. The technician is outside giving instructions, and there are like stickers on the ground saying, put your leg to the left, right, etc. And that's about it. The actual report is ready. Within 10 to 15 minutes, the full test is done, preparation, screening, and the AI, and the report. All is ready immediately, and the ASHA worker or right now a person who knows how to use a computer or a mobile phone is sufficient, can actually generate the report instantly. We are not saying that we'll replace all the existing methods there, but this is a screening method. Instantly, you have a red, yellow, green, and a risk score, which indicates whether the lady needs to be taken to the hospital now or she's safe, and maybe she can be followed up in 6 months, the yellow one. This is what we call as thermalytics. It is purely AI-based solution. It's a software AI-based solution. The existing devices, which are thermal cameras, they are used. The method of using thermal sensing for breast cancer is not our idea. It's been around for some time, but it has failed pretty badly because of the accuracy requirement. By adding AI, which is actually one of its kind, with 36 patents around the world. We even have 13 patents in the US and 15 in India, et cetera, right? So the main thing is the AI, which is the differentiator. We convert the temperature map to a cancer health report, marking the area of likely malignancy, giving scores, et cetera. Because we are, with the pilots and so on, we deal with, low-skilled ASHA workers. There could be errors. So we have many AI patents to make sure the images are taken properly, guide the ASHA worker immediately so that, errors don't crop up till the, reports are generated. Of course, when the full detailed report is generated, it goes to a doctor. Like, for example, if we do an imaging center, let's say, like Mahajan Imaging or Apollo Center, right? We can actually generate a detailed report which goes to the doctor, showing the area and why is this a problem. Is it because of vascular abnormality? Is it because of inflammatory action that we are seeing? Is it because of milk duct blocking? What we call as explainable AI is also put into the picture so that, it can go to the next level and have different diagnostic workup. That is for the detailed reporting for imaging centers, etc. But for a rural area, because we want to keep the cost down, we just give a red, yellow, green with a score which any ASHA worker can understand to say whether it needs to go to the next level or not. I don't want to spend too much time on this graph, but for those of you who are very aware of the sensitivity, specificity needs, the quality of doing it, yes, we have compared this with biopsy result. In this particular study, every person went through our test, and then she went through mammography. If that's dense breast, she did an ultrasound. And if any one of them were positive, she did a biopsy as well. And trust me, the orange bar tells you that we have not missed any cancer, touch wood, which was detected by either a mammo or an ultrasound. We are not saying that we are done, right? It is a screening method. If this is positive, she needs to do the rest of the diagnostic imaging. Of course, biopsy is the final golden truth, and that is when the person becomes. But we tell who among these 1,000 people need to be taken to the hospital or the nearest district hospital to do the further testing. And of course, we have to keep the false positives low as well. We don't want to burden the system by taking too many people out there. And we have more than 45 publications in this, including the dearest Lancet Oncology. Yes, we have regulatory clearances. I'm so glad the CDSCO came up with a really, really stringent software-based medical device regulatory, which since last year as well. Earlier, it was there was not very tight, control on AI-based devices because, you can show these results with different type of data. We have to make sure, just like US FDA does, proper clinical protocol has been followed when we do this result analysis, etc. We also have European clearance. We are by far the only Indian startup which has both the US and the European clearance. Of course, apart from India, we have in Africa, Philippines, etc., etc. This is a purely made in India product, by the way. So far, more than 2.5 lakh women have been impacted around the world, most of them being in India. Now, because it is so unique in the world, now 20 countries have, beyond India, have actually started using it. But of course, because of the way it can be used either in a hospital or in a corporate setting or definitely in a rural setting, and it can also be used at home because of the portability and accuracy part of it, it is actually like a universal screening method which can detect at stage 0, stage 1, these kind of abnormalities. And these are some of the ASHA workers we train. Sometimes they're used for awareness creation. Sometimes they themselves actually operate the device. We work with foundations, cancer societies to actually go to these people so that there is enough trust built in when we reach these people. We also have a mobile medical unit for, let's say, if you want to go and tribal areas, etc. So I just want to, we've done several studies in Karnataka, Maharashtra, Andhra Pradesh, Uttarakhand with ALVL, and Northeast, and one of the ones which we did recently in a very scientific manner was in Punjab, where 15,000 women were screened, and there were some lost follow-ups, and it's normal, and we know that, but still, we found 27 people, confirmed to be malignant with histopathology, started treatment, and most of them have completed the treatment as well. This is first of its kind where AI alone is used to screen patients, and then, of course, whoever were positive went to the next level. Just to give an idea, a similar study on 25,000 patients with hand examination, which is the standard for screening today in India, had detected only 11 cancers. We have more than 3 times more cancers detected, proven that it is cancer. So these people were lying around despite spending so much money and effort on the ASHA workers training, we were getting missed. So this is one such study published in European Breast Cancer Conference. It got accepted in Nature. I'm waiting for it to come in print. So this shows that there is accuracy, there is quality, there is affordability, there is, now we have done several pilots. My question to you all and people on the dais is, how can we scale this to the whole of India? We are ready to scale because all we need to do, it's all cloud-based. One day we can just do crore of women easily. And trust me, in India alone, we can save lives of 250 women every day. And not only women's life, the whole family will be very, very happy. So we are here to save lives with using AI. Now, some of the points that were raised by the panelists before were about HTA. Yes, we have done health technology assessment with Kalam Institute of Technology. We have done pilots in ICMR, National Institute of Cancer Prevention. We've done pilots in multiple states. And best part is privacy aware. People need to feel like going and doing it because no one sees or touches the person during this test. And we see excellent adherence to the camp and so on and so forth. So if based on this panel, if you are able to scale in Maharashtra, Madhya Pradesh, or several parts of India, I think on behalf of women of India, I would say Jai Hind again. Thank you so much.
Thank you, Dr. Manjunath. And I just want to tell you that the number which we have in mind in UP alone is 3.5 crore women. Thank you very much. So now the best is for the last, or the last is for the best, and request Mr. Siddhartha Bhattacharya to share his insights with his rich experience in primary health.
Thank you, Dr. Lal. And thank you, sir, for getting the industry together in a consortium form with FICCI, OMAG, Nat Health, and kind of creating a united front, working hand in hand with government to achieve this very, very important agenda, which would be a cornerstone for universal health coverage anywhere around the world, particularly in India. I would like to just also thank the formidable set of speakers, luminaries in their rights. They've covered most of the domain very, very well. As we all know, healthcare is a subject where world's the number one economy spends nearly 17% of GDP, but doesn't have the top 10 health outcomes. You have other examples where there are countries that spend 5 to 6% of their GDP into health, 4.5%, even 5%, and they have top 10 health outcomes. So it is an anomaly, right? To be able to achieve the right health outcomes for the population, as per WHO and many other top economies around the world, primary care is that level. And unless the pyramid, the health pyramid, the entry point into the health pyramid happens through a well-functioning, robust primary care system, we are not going to get value for money into healthcare, and that is always going to be a question that would be asked, and primary care is a foundational element thereafter. Most recently, you may have seen in social media, at least I picked it up, there was a ranking that was given about to reach a specialist, how many days it takes. Right? And India was top of the chart because it's less than 7 days. And while that is a great story for India, but it's also very important, it has immense bearing. If we really had gatekeeping and we had a continuum of care very well managed through a robust primary care system, it is possible to reach in 7 days, but you may not want to reach in 7 days because of obvious reasons, right? So I think there are about 3 or 4 broad themes which I think from a private sector or an industry perspective, prior to Nat Health, I was with Access Health, and I was fortunate to be a part of a study where we did a landscaping exercise of primary care, all the innovations that have happened across states, either public or private. And the 3 or 4 things that jumps out, and I think where industry can play a major role. Primary care, ultimately, if there is one large use case for digital health, the killer application of digital health in India is primary care. And it is not only digital health, a whole lot of other things. The 3 or 4 broad areas, one is what is the monitoring of a good primary care system? Because eventually you are paying to a large extent into inputs, and to be able to pay for performance, there is a need to not only have a whole lot of data pulled together, but the data has to be triangulated and probably matched with independent performance monitoring systems. Things like vignettes, for example, things like standardized patients. There's a lot of weapons in the armory. And to be able to design a robust monitoring system for primary care at a population level, I think it would be a huge leap if we can do for one state like UP. It can be used across many states. But I think there a public-private partnership in terms of real strong data analytics people can do quite a bit of help, and I'm sure we'll look at it in this as a part of this exercise. The second broad area is the registration of population and really screening the high-risk part of the population, if not the entire population, which can get expensive. We heard about Niramai earlier today. But really, the world of device-led medical technologies, right? Strong ability to have a strong IT backbone that integrates. So I'll give a simple example. You can either have a 12-lead ECG done by a doctor with a compounder with the patient lying on the bedside table, and the prescription is generated thereafter. Or you actually can do an 8-lead ECG today where the data is captured by a device, seamlessly transported somewhere else, where the machine probably 95% of the cases gives the prescription. And it can be overseen by a doctor depending upon the need. But you can have a device-led sort of a digital diagnostic systems. You have advanced portable diagnostics which can really take you to the last mile. Examples, case in point, is medical mobile units that have been tried in many countries around many states in India. So that sort of a screening, monitoring, digitizing the front end, and task shifting to be able to simplify the front end, the workload, being able to do a lot of the work where capacity exists as opposed to shifting that capacity elsewhere in the front line where it's harder to get. That would be a big, big area. In terms of being able to create seamless referral pathways that connects the PHC, CHC, the secondary healthcare, and really being able to manage the gates and doing optimum level of care at the right levels, that requires continuous monitoring systems, technology integrations, being able to redesign the workflows and the individual, the skill set level at every stage. Not only HR skill set, but HR skill set coupled with the technology and the devices to serve the population, and having team-based structures from doctors, nurses, and the allied health workers, which are mobile, with incentives being aligned to outcomes. There is a role for private sector to play to be able to do that sort of skill building, capacity building at scale. And finally, I think the point has been made today in terms of wherever there is large data, you can have large database models that can predict. And to a large extent, this is important from a research perspective, from a system improvement perspective, as well as from a quality and standards and upkeep perspective in terms of generating that value for money argument. In the world of more money for health, and for the world of more health for the money being generated. Primary care is the intersection between those two and the sweet spot. So I'm deeply thankful to Dr. Lal for this opportunity and the ability that he has brought this formidable group together to really focus on solutioning some of the issues that have been discussed, and look forward to the further conversations. Thank you.
Thank you very much, Siddhartha. In the interest of time, actually there is no time for questions, but I will allow just one question from the audience. Only one question, please. Yes, Dr. Ina.
So good morning, and I think it was a wonderful session because it highlighted the use of actually, trying to close the loop, not only just promoting and preventing health, but also closing the loop. Taking an example from a study that we had done with the Uttar Pradesh government actually a decade back in the NCPDCS, where we had actually screened 1 lakh population for diabetes and hypertension from Dr. Lal Path Labs. And what we did present then also was that, despite possible 30% abnormal results that we got, we were not able to close the loop on follow-up monitoring or what intervention really happened. From the study that you have done, almost 40% were lost to follow-up after screening with Niramai. So, the effort or the technology use being there, how can we even close the loop with technology? Like, as an example, if I take possibly core biopsy of the positives right there, or at least as a follow-up, very soon after, and a digital pathology and AI solution to be able to, kind of cover that through and give the good diagnosis, quality diagnosis, without geographic constraints of histopathologists being there. That's one solution. It would definitely, kind of require a policy framework for the public and the private sector to work, bridging the trust deficit gaps, that are there. So that was just one of the things, and I think what and how can that be done to, enable more of digital pathology, more of like telepathology availability. So that's something that I would urge the panel to do.
One way is to give up the patents. One way to make these technologies accessible is to give up the patents voluntarily. So then it will be available for 4 or 5 people to make, and then the government can procure. Most of the time when government has to procure these innovative technologies, it is the right pricing which becomes the issue. How do you assess that this is the right price? So in a country which is so vast, if you give up the patents, 4 or 5 people will start making, and then it is easier for the government to procure because the market is anyway infinite, almost infinite. That is one easy way to do when you do this procurement of innovative technologies. I would be very happy to see your HTA results because the list of HTAs that has been given to me by DHR does not cover this Niramai thing. Coming to your questions, the screening has to go in hand with the diagnostic facilities, and that is a challenge in most of the cases, because if you do a lot of screening and then you are lacking on the confirmatory diagnostics, then we have a problem. But we have to work hand in hand, and we are still looking for a solution. Thank you.
So, just one follow-up to that. A lot of cost is actually not considered of what would actually happen downstream. So
Yeah, Dr. Ina, let's take it up, one-to-one later. We have already crossed our limit many minutes back. So thank you very much, ladies and gentlemen. And I thank my esteemed panelists for being here today. Thank you very much.
Thank you very much, sir, and all the esteemed panelists. It was indeed a great session. And now we are moving towards the medical education, the road ahead. The session will explore the themes aiming to identify effective strategies and necessary reforms to prepare future healthcare professionals in India. We're not taking a break, but we shall request you to give us a time of for a minute to change the cue cards and the dais to be set. We also have a parallel session of startups pitching, which is going on the first floor, Gulmohar Hall. So kindly seek your interest and you can move forward to either of the sessions. Startups pitching session on innovations in digital health.